Even though it's idiopathic, there's almost always an underlying shoulder pathology that started it, and it's usually a rotator cuff tear. I think the other thing that sometimes gets overlooked is the suprascapular nerve, and so I hydrodissect the suprascapular nerve with all of my adhesive capsulitis treatments because that nerve is usually implicated to some degree. And then the other thing is, even though it's idiopathic, there's almost always an underlying shoulder pathology that started it, and it's usually a rotator cuff tear.
Yeah.
And so the question is, do we address just the adhesive capsulitis first and then later on address the rotator cuff, or do we address them both at the same time? I've done both. I've had patients where we just addressed the adhesive capsulitis and they get better over time, and then sometimes we'd go back in and treat the rotator cuff or whatever other pathology was there that might have led to that. Other times we've done it together at the same time. If I recall, the only times I've done that are when I used adipose or bone marrow, so a stronger type of treatment. And they're all out-of-state patients. And so we didn't have the luxury of saying, okay, we're going to do the joint hydrodilation, and then in 4 to 12 weeks, depending on how you're doing, we're then going to go back in and potentially do it again, or we're going to go back in and now actually treat that supraspinatus or subscap or whatever it is that kind of contributed to the adhesive capsulitis kind of forming.
It's interesting you say that there's a high likelihood that they had a rotator cuff tear at some point. Because when these guidelines were old, they're from 2013, so it's not that old, but they said that early loss of external range of motion with the arm at a 0-degree abduction position and intact rotator cuff muscles was a hallmark sign of adhesive capsulitis.